Okay, well, it's 7:02. We're going to go ahead and get started. Want to thank everybody for coming on this Zoom webinar. I know we're sort of all getting sort of tired of these things, but I think this is going to be a great and informative discussion about Barrett's esophagus and specifically detection of dysplasia in Barrett's. And I'll go ahead and start introducing folks. We've got Dr. Dan Lister out of Arkansas with the Arkansas Heartburn Center, and then Dr. Mike Smith at Mount Sinai, who's a gastroenterologist. So we are sort of teaming up on Dr. Smith this evening. We usually at the AFS have a true 50-50 split, but this is a little surgeon heavy this evening. I would ask, as I start to share my screen, that folks put their questions in the Q&A, preferably over the chat, and we were going to get to those questions as we go. The idea here is that we're going to be a little bit more interactive than hopefully the average Zoom meeting, and we're going to stop periodically and talk and answer questions that come up in the chat. So we are going to look at our agenda, I believe. Maybe we are not. All right. Well, our agenda basically is going to be going through Barrett's esophagus, just some quick high points from my perspective. Then Dr. Lister is going to talk about some of the epidemiology, as well as what makes for a great EGD. And then Dr. Smith is going to talk about chromoendoscopy. I'm going to talk about confocal laser endomicroscopy. Then Dr. Smith again is going to talk about volumetric laser and endoscopy. And then finally, we're going to talk about Watts from Dan Lister. For some bizarre reason, my screen won't advance. That is great. Kate, do you happen to have any quick, or anybody have any quick ideas about why my PowerPoint would not advance? We're going to keep trying at this.
Hey, Trip, try clicking on the PowerPoint screen. Sometimes you're off screen on that.
Yeah, there we go. How about that? Can you see that now? Maybe not. Let me share that and then see how that goes. Okay, great. So that's basically our agenda this evening, and we're going to get right to it. So in my view, this is, this discussion is about this battleground zone. So if you haven't seen a Cellvizio image, and we're going to see some of them a little bit later, but this is the squamo-columnar junction as seen through PCLE. Cellvizio has the lock on that market. And, I think that one of the reasons why we're talking about detection of dysplastic Barrett's is because we know that that's the next step leading to esophageal cancer being one of the fastest growing cancers in the westernized world. Here you can see relative rates compared to some other cancers where we really bent the curve. This is looking more like a COVID-19 curve in California, if Dr. Lipham is listening, 600% rise since 1975. This is some SEER data, and I think this highlights the fact that white males like myself are at increased risk for esophageal. See by sex and race on the right, white males are much higher, black males, white females, and then black females. I'm going to go ahead and skip right through that so we can keep moving along. I think that this is an important slide that I like to use because we talk about, often when folks talk about Barrett's, they mention that, oh, well, the relative rate, year over year is pretty low in progressing to esophageal cancer, but that's in low risk patients. So you really need to score your patients, look at them as individuals, not just do they have cancer. So you got to take length into account. You got to take male sex into account, smoking, and then do they have any low grade dysplasia. So if you're in the high risk category and you have an annual progression of 2.1% per year, that is really high. And so I don't think all Barrett's is the same. I'll just go ahead and share that I have Barrett's esophagus, and I'm in the intermediate risk group. So if my year over year progression is 0.73%, I'm going to pay attention to that as a patient. And then as a physician, I'm going to really pay attention to that as well. So we're going to go ahead and turn it over to Dr. Lister, who's going to, again, talk to us about what makes a great EGD, and then some more in-depth review of Barrett's esophagus.
Thank you, Trip. All right. So one of the things that we've seen as an increase in upper endoscopy, we have seen a concurrent rise in the detection of Barrett's, both long segment first and then short segment Barrett's. And this mirrors the increase in adenocarcinoma that we see. And it's very concerning as we go through the years, but this is the basic crux of what this talk is about tonight. As we progress from no dysplasia to low-grade dysplasia to high-grade dysplasia, hopefully we will ultimately be able to detect these patients earlier and treat them before they reach the enemy, which is adenocarcinoma. Trip showed the slide of the increasing 700 to 800% increase since 1970. And that really doesn't show any sign that it's going to slow down. As Trip also said, dysplasia plays a big role. If you do not have dysplasia, in this study, 2% of patients progress to adenocarcinoma over about a 7-year period. However, the patients with low-grade dysplasia had a 7% progression, and patients with high-grade dysplasia had a 22% progression. So it's very critical that we identify the patients with dysplasia and to correctly stage their dysplasia so that we know their ultimate risk of progressing to cancer. And this is kind of what we're looking for. We're the ultimate needle in a haystack. So as you all know, Barrett's surveillance, currently the standard is Seattle protocol, random 4-quadrant biopsies every 1 to 2 centimeters through the length of the columnar lined esophagus. The problem with this is it can be quite time consuming. And in a study published in 1998, they looked at pathology reports and operative reports through a series of patients. In community practices, they found that Seattle protocol was only followed 51% of the time. And I think that may be even a stretch. If Seattle protocol is followed correctly, you're still leaving 94 to 96% of the mucosa unsampled. And Stu Speckler, very eloquently displayed the problem with that is that the dysplasia has no distinct features when you're looking at it endoscopically. And you're basically throwing darts blindly at a dartboard and you hope you hit the target. The more we biopsy, the higher your yield is, unless we have ways to direct our biopsies more effectively. And that'll be a large portion of the talk tonight, followed by a way to sample more extensively. Probably the first thing that I want to point out is that, a quality endoscopy is important. you really need to spend a lot of time retroflexed and looking. You know, this patient obviously has about a 7 by 5 centimeter hiatal hernia, transverse dimensions with about a 4 centimeter axial height. And as surgeons, we feel that that's very important for the GIs to say that in the report. But if you can look retroflexed, you can see along here, let me back this up just a little bit. These are the palisade vessels, which this is the actual end of the tubular esophagus. So this valve has become incompetent and you've got effacement of the valve. So you're actually not seeing where the true end of the esophagus is. And in this view here, if we go from the diaphragm up, you can see that the palisade vessels here are the actual end of the tubular esophagus. So the columnar lined epithelium starts there, and that's where you need to start biopsying and really take your time to look and look at these areas of glandular appearing tissue, which is more than likely Barrett's and hopefully not dysplasia. As you can see, this patient has some erosive esophagitis a little higher up, as well as a Schottky ring. In this study here, one of the easiest things that we can do is just take more time to look at the Barrett segment. Regardless of Barrett's length, this study showed that the longer you take inspecting the Barrett's, the higher your yield for detecting high-grade dysplasia and cancer is. So it's really important that we take time to study those areas, look closely under white light endoscopy and narrowband imaging. And then Mike's going to talk about some other modalities that we can use to help increase our yield.
Terrific. Thanks very much, guys. Let me go ahead and share my screen. And we're going to start talking now about digital chromoendoscopy as a first step that almost all of us have in our armamentarium for identifying dysplastic disease within a Barrett segment. And you know, the great thing about this is we've now reached a point where this kind of imaging is available no matter what brand of endoscope you're using, and almost all of them. There are different versions. I'm going to show you them, but you'll see that the takeaway points are very similar for each of them, and that is that specific wavelengths of light or filtering images through specific wavelengths of light bring out certain features that allow you to identify areas that are more concerning and help you to target your biopsies or other tissue sampling to be able to evaluate for the presence of advanced disease within a Barrett segment. So first off, let's start with the one that I think the majority of us probably have access to, and that's narrowband imaging. And again, it's really altering the white light source to consist of specific wavelength bands, in particular, two of them, one in the blue and one in the green spectrum, as you can see at the bottom of the slide. And that takes advantage of the scattering and absorption properties of the tissue that you're looking at. In particular, these wavelengths are strongly absorbed by hemoglobin. So seeing blood and vessels is something that you can see, and they penetrate only the tissue surface. So they're very ideal for enhancing the contrast between the blood vessels and the tissue surface and bringing out some of these very subtle topographic features. The capillaries on the mucosal surface are displayed in brown, and the veins in the submucosa, ultimately with the hemoglobin absorption there, are displayed in cyan. And here's an image that I'm sure many of us on the webinar tonight are used to seeing, and that's Barrett's esophagus with the white light, high definition white light endoscope on the left and narrowband imaging on the right. And you can see that the same area, the same tongue of Barrett's extending up along the right side of the esophagus here is visible under both types of light. It's just that the contrast that's provided by narrowing the wavelengths that are utilized in the NBI image increases the contrast and really demonstrates a really nice demarcation between the intestinal metaplasia and the normal squamous epithelium. Now, when you're thinking about identifying areas that have dysplastic disease, which is the focus of our talk tonight, you could see that the mucosal pattern as well as the vascular pattern in those capillaries can be very helpful. And if you see areas of irregularity or a lack of homogeneity of the appearance of the area, that's going to lead you towards a higher index of suspicion that that area has dysplasia. And you can see from the left side to the right side, again, you can see the Barrett's area in both, but the ability to see that vascular pattern and the mucosal pattern difference in that focal area down towards the bottom of the screen is going to have you target that area now for a specific biopsy. And that change is really only very subtle on the high definition white light image and likely to be missed even if you take all that Barrett's inspection time that Dan was talking about. So I'll leave this one for a second for you to look at. Is there anything suspicious in this segment of circumferential Barrett's? There is a squamous island, I will tell you, down there on the right-hand side, and looks like a little bit of squamous tissue off in the left side as well. But for the most part, this is a pretty circumferential segment of Barrett's, and pretty easy to not see the more subtle findings that come out when you have close inspection with narrowband imaging, where you've got a very abnormal topographical pattern, almost looks like cobblestones, that are in an area of high-grade dysplasia. And in fact, there's an area with flat, depressed high-grade dysplasia, which is even more concerning there, that you really can't see on the white light image, but is really brought out very nicely by the narrow band. You do see the squamous islands, and again, there's that contrast between the intestinal metaplasia and the squamous mucosa. But the subtlety that you would see really is brought out and made much more in your face by the addition of the narrowband imaging to the way that you're inspecting the tissue. And of course, you can also find areas of adenocarcinoma. Here's a small one in an area, an island of what looks like an island of Barrett's, that if you're not paying close attention, could look like it's just sort of sitting on top of a fold in the esophagus that's due to the tortuosity. But in fact, you could see that the mucosal pattern is quite abnormal, and you would be targeting this for an additional tissue sample. So, been a number of studies out there. I just want to highlight two of them very quickly, demonstrating improved detection of dysplasia by using NBI. This one from Herb Wolfson down at the Mayo in Jacksonville, showing that he was able to upstage the grade of dysplasia in 18% of the patients undergoing a tandem endoscopy study of NBI versus high definition white light endoscopy. This published over a decade ago, and none of the Barrett specimens that were evaluated with white light following NBI had an upstaging of their dysplasia grade. And in fact, the biopsies directed by NBI findings detected dysplasia in over half of the patients, compared with 43% of the patients who had biopsies taken based on their white light findings. So, you know, the important point here is that the NBI and all of these modalities make it easier to see the abnormalities. They really can train your eye back when you're back on white light to look at a segment more carefully and detect it. But the fact is that it really facilitates it. And when you've got especially a long segment of Barrett's, this is a really nice way to find that needle in the haystack and make sure that your tissue sampling is covering the most suspicious, most concerning area. In fact, there's another study by Sharma published earlier in this decade, again, looking at the detection of intestinal metaplasia being very similar in both of the white light and the NBI groups, but the NBI patients had fewer biopsies taken and detected actually more dysplasia by about 50% over what was detected by using the white light only. And all of the areas of high-grade dysplasia neoplasia had an abnormal NBI that was noticed by the endoscopist. Normal NBI imaging on biopsies taken did not seem to harbor neoplasia in any of the studies in this particular study cohort. So a couple of others just to mention very quickly. This is FICE, or Flexible Spectral Imaging Color Enhancement. It's based on a spectral estimation technology. And again, you can see here, this is kind of a post-image processing. You've got the red, the green, and the blue images that are passed through these special filters and then brought back together. And you get this final processed image. And it's this post-processing that allows these structures, again, the blood vessels in this particular case, to have an enhanced appearance that allows you to identify the abnormalities. Blue light imaging being one of the newer technologies out there, again, focusing on this 410 nanometer wavelength because of its absorption by hemoglobin. And you could see that the white light versus the blue light imaging changes the pattern of the light that's emitted, and the result is you get this enhanced contrast in the images that are shown up on the screen, as evidenced here by these two pictures of the white light and then the BLI on the right-hand side. Eye scan is another option that's out there with the digital image enhancement that has three options that add to the normal imaging. One that looks at the surface, one that looks at contrast, and one that looks at tone. And I'll show you a brief pictures with looking at those. The SE image, which is the one in the middle here, looks at the delineation of mucosal structures and tissue folds. So again, looking at the surface for that topography in areas that look concerning. The CE, the contrast enhancement, looking at the vessel appearance. And then the TE, accentuating again the mucosal pattern and the vascular structures. So you get all of these different images, you could put them together and evaluate, and you can see some of these more subtle changes be brought to the forefront so that they can help you to evaluate the tissue better. And if you look at the evolution of the GI Society guidelines, and since I've got two surgical partners, I'll focus on those quickly. You can see that as those guidelines came out, the endorsement of digital chromoendoscopy has really, there's been a warming trend amongst the societies. And as the new guidelines come out in the next few years, I think that we're going to see that it's potentially going to go on beyond just the narrow band imaging, as more and more of these techniques get data behind them, but also really, as I said, sort of go to the same thing. They're using these specific wavelengths of light. They're focusing the images. They're using the contrast enhancement. They're looking at the vessel pattern, and they're looking at the absorption at the mucosal level and the surface level to really give you the definition that allows you to see the subtle changes that will help you to target your samples. So with that, I'm going to turn it back over to Trip to talk a little bit about taking better optical biopsies.
Okay, thank you, Mike. That was great. I think we'll pause here for a second and see if there's any questions. They're not just yet, but feel free to weigh in with opinions or questions on these, and we can discuss them. I'll ask a question of Mike. I mean, we talk about narrowband imaging, and we're about to talk about some really cool technology to enhance our ability to detect dysplasia in Barrett's and Barrett's itself. But I find often that, starting at a new endoscopy center, I'll say, let's do some narrowband imaging. And the technology, the techs in the room will say, oh, I've never even seen that. That's really cool. And which really scares me. And probably of all the things we're going to discuss here, I mean, just doing a basic good endoscopy, as Dr. Lister mentioned, and then using NBI are just key. And yet I think it's underutilized. And you mentioned in your last slide, I mean, I think that the guidelines are way behind where the technology is. What are, what's the training like? I mean, are we forcing a gastroenterologist to do this? I know that surgeons don't do it all the time because they haven't, they think they've been trained, but maybe they haven't been trained as well as they should. And so I feel like it's underutilized. What's your opinion?
Yeah, I would agree. And I think even in the GI community, those who are aware of it and are comfortable using it, those who trained and were exposed more recently, and were exposed to it during training are more likely to continue on as attendings using it, I believe, and in their practice. But the fact is that it's still the easiest thing to do, especially as the high definition part gets better and better, is people just use what automatically comes on when you turn on the scope. And if they don't take the time to look at it and they're not stopping to hit the button and enable the feature, it's easier and easier just to pass it by because the optics are so much better, even with the white light exam. But you're absolutely right. It doesn't cost anything more to do it. and it takes a very minimal amount of time to add it to the process of inspecting the segment. And I would make an argument that just as important as it is to look at the overall amount of time you spend looking at the Barrett's, I think adding in this advanced digital chromoendoscopy as part of that Barrett's inspection time is really critical. So, you know, I think the nice thing is that all of the techniques we're talking about here tonight help you to find this more serious disease and appropriately risk stratify the patient for their chance of progressing to cancer. But if you have the tool available and you don't even make use of it when it's really minimal imposition to do it, you're shortchanging your patients. So, you know, I think getting that message out more diffusely to folks, particularly as people get maybe a little bit more comfortable using it to look at colon polyps. Maybe now if they realize they can turn on the same feature very quickly and look at Barrett's, even if they see a lot more polyps than they do Barrett's, it can be very helpful for their patients and really for them in their practice.
So Mike, we have a question from Reg Bell. Of the advanced imaging techniques beyond MBI, which do you think has the most promise?
So I think we're going to get into some of those techniques in the next segment. So I'm going to withhold judgment on that until we get a little further. But I would argue that with the digital chromoendoscopies, as I said in my opening remarks, I think that just using them and getting familiar with them and using them to train your eye better for when you do a high definition white light exam on a Barrett segment can be very helpful. And I don't know that necessarily just because the NBI was the first to market and the one that's had the most data behind it, that the other techniques are necessarily inferior to it. The best technique in this case is the one that's used. So I would say as it comes to digital chromo, whichever one you have access to, turn it on and use it and help your patients. And don't be too upset if you're a Pentax shop or a Fujinon shop and you don't have access to NBI. The quality of those respective techniques are getting better and better.
Fantastic. You might comment, Mike, as I start, well, if I share my screen, you won't be able to comment, but he may have been talking about like the blue light and some of the other things that you were discussing. But yes. I think we probably need to move on and push through this. So I am going to share my screen again.
I think as we think about this, let's leave some time to circle back if there are more questions on that, but let's make sure we cover all of the ground.
Perfect. Okay, so I'm going to talk about optical endomicroscopy, really probe-based confocal laser endomicroscopy. For those of you that are not familiar, it's a probe that can go down any endoscope, and it's laser-induced fluorescence effectively. And so we're taking, you know, basically microscopic images of living tissue. And the idea and the hope here is that we can reduce the need for really costly biopsies, especially when you're talking about long segment Barrett's, which is where we're going to find that dysplasia. Again, if you think about what Dr. Lister mentioned, if you have a long segment of Barrett's and you're doing appropriate Seattle protocol, well, it's really hard and it's time consuming. You've got a huge bloody field. And I think that's where we start to miss opportunities to catch dysplasia. So with the Cellvizio, we don't have that issue. We can cover all the or a vast majority of it in a short amount of time. Like I said, it's compatible with all endoscopes. There's really good data behind it. We're going to go over some of it, but I would say if you aggregate the data, you're getting a sensitivity of nearly 100%, specificity of greater than 80%, and good positive predictive values as well as negative predictive values. And basically every study out there shows that you're going to detect Barrett's 2 times more likely than with traditional biopsies. And that goes back to A, are you biopsying the correct area? And B, is your pathologist going to detect it? So this is the setup in the endo suite or the OR, depending on where you're doing this. And so it's a freestanding unit. It's got its own screen, and we put it, actually we superimpose it onto our endoscopy screen. So that's really easy to do as well. And it does take a little bit of time. It's I would say it's about 3 to 5 minutes, depending on your segment and that you're looking at. But for those that are, I always say that I'm a sort of novice endoscopist. I think the gastroenterologists are more facile than I am, and I know it can be more, they can be quicker in their hands. These are some images that you will get. So on the upper left is just normal squamous mucosa. On the upper right is what we would call NERD, non-erosive reflux disease. You get these kind of islands where it's kind of thinned out and you can actually see the capillaries just under the surface of the cells, and it's those are pretty neat. Med students really love to look at that because you can see the actual corpuscles going through the capillaries. On the lower left hand corner is regular Barrett's, so you can see the goblet cells. So if you see those goblet cells, then you're going to, that's automatically Barrett's esophagus. And they jump out at you. So it's not that difficult to be your own pathologist. And in fact, it's really rewarding to be your own pathologist, I would say. We've got Barrett's again with some goblet cells down below, but in the setting of dysplasia, and same way on the right. If we talk, we looked at that progression slide. If we think about progression, and this is, on the top is from an endoscopic view. Again, we've got squamous epithelium or NERD. When you look at the Cellvizio image, non-dysplastic Barrett's in the second image. And now we're getting into dysplasia. You can see disrupted borders there. And then finally, esophageal adenocarcinoma with, again, a kind of complete loss of that villiform structure, really irregular epithelium and epithelial borders. This, again, is just correlating the Cellvizio image with histopathology, going from, again, non-dysplastic Barrett's to low-grade dysplasia to esophageal adenocarcinoma. And it takes a little bit of training to really start deciding whether you're looking at cancer or dysplasia. To me, I get asked this question all the time, is that, truly important? I don't think it is. We're not using Cellvizio to say, okay, well, this is low-grade dysplasia versus high-grade dysplasia, or even cancer. We found an extremely suspicious area in a segment, usually of Barrett's, and we're very concerned about it. So we're going to biopsy that and target our biopsies so that we can really get some good tissue. And you might even use some of the other techniques that we're going to discuss here tonight. What are some data behind this? Well, this is a study that I was lucky enough to participate in, and you'll probably recognize many of those on the study. The idea here was we were taking novice users actually of Cellvizio and seeing if we are getting the same data, that basically 200% increase in diagnosis as some of the early data showed with expert users. And the answer was yes. If you look over on the right-hand column, we identified intestinal metaplasia or Barrett's 57% of the time, whereas under traditional biopsy, it was only diagnosed 27%. Dysplasia, we were much better at identifying dysplasia, even amongst novice users, than traditional biopsies. So this is a really powerful tool where you can do it in real time. You don't have to wait for those biopsies to come back. You can target your biopsies of suspicious areas, and I really enjoy using it. This is a AGA white paper talking about CLE in particular, basically Cellvizio, and it met the PIVI thresholds for eliminating random biopsies for Barrett's surveillance at referral centers. So what's the rub there? Well, they wanted you to become expert at using it, which just means, using it. And I think we showed beforehand that really there's a little difference between a novice user and an expert user. Certainly the standard remains to continue your 4-quadrant biopsies and targeted biopsies. Again, I use it personally. If I see Barrett's, I'm still gonna biopsy that, but I target them. I really don't do the 4-quadrant biopsies, but you probably want a histologic diagnosis of Barrett's. Although in some patients, again, that may or may not come back. We did our own study when I first got to Dell Medical School, where the pathologist kind of pitched a hissy fit about doing both Watts and optical endomicroscopy. We did our own study, and we again showed out of 50 patients that we had a 200% increase in diagnosis, and that the pathologists or myself in targeting those biopsies were not as good. In fact, we did 4-quadrant biopsies, and the data is the same. So the data to me is consistently boring in that it continually shows increased detection rates of both dysplasia and non-dysplastic Barrett's. This is from a European consensus group. I think there were 25, 26 gastroenterologists here, getting to know our GI colleagues intimately through AFS and our local centers and around town. It's hard to get them to agree on anything, but I'm just going to highlight 2 areas of strong agreement in this, out of this consensus group. And basically, should CLE be considered in the evaluation of Barrett's esophagus? 95% agreement that it should be considered. And I think more importantly, when you look at dysplasia, there was 100% agreement that it is clinically indicated in patients for surveillance with known dysplasia. And I think when you talk about ablating Barrett's esophagus, it's an extremely powerful tool to identify whether you need to go back and continue ablation. So if you're going back for a second look, and you can use optical endomicroscopy to in real time decide where you're going to ablate, do you need to ablate, et cetera. So whether it's decreasing the number of biopsies, which are extremely expensive for long segment Barrett's, or utilizing it in the setting of ablative therapy, I think we can decrease the overall cost of an episode of care here, and we can increase our rate of dysplasia detection as well as Barrett's in general. So I will pause there, and before we head on, we'll also stop to see if we have any additional questions out of the group. And there is one. If you have a longer segment of Barrett's, since CLE has such a small field of view, how do you decide what areas of Barrett's to look at, or do you try to look at the whole area? How long does it take to fully evaluate, say, a 1 centimeter segment of Barrett's? So I try to go through and diligently go through the whole area. You can't get 100%, but you can move, if you can stabilize the scope. One of the tricks is we put a cap on the end of the scope. And if you can stabilize that scope, you can cover a lot of ground. How long would it take me for a 1 centimeter segment of Barrett's? I would say it would take me, 3 minutes. Really, I try and concentrate on the squamocolumnar junction as well as down low, where you're going to find many of your cancers. So I hope that answers that. Any comments from Dr. Lister or Smith?
I would argue that the technology I'm going to show you next addresses the potential shortcoming of CLE that was raised in that question.
Okay. Go ahead, Dan.
I would say excellent presentation there. I do think that the technology has a very useful, where you pointed out, in the patient that you're doing ablation and you think that you've reached CRIM, with Solvisio, you have the ability to look in real time to determine, do you need to do more ablation, or are you done? As opposed to, if you don't have that technology, you've reached what you think is crim, you biopsy them, and then if 4 days later your biopsies come back, oh no, there's still Barrett's there, then the patient's having to have another endoscopy, another sedation. So I think it's very useful in that technology, in that spectrum.
I would just caution people who are considering that in the audience to make sure that you know your reimbursement schedules, because in several states, if you do both advanced optical endomicroscopy and ablation in the same code, in the same procedure, you will be in the hole significantly for what they will reimburse, as you have potentially two very expensive technologies that you're using at the same time. So you want to pay attention to that, just so that you're able to continue using the technology and your hospital doesn't shut you down.
Well, good point. Good point.
It is a good point, but I think that, we've never had an issue with that. So I don't know what the answer is there, but I think, again, when you think about value-based care and you're just going to go in and start pounding away with your RFA or whatever ablative technology you're going to use, I think that there is a value there. And more importantly, what's the right thing to do for patients? There was one other question around what does it take to become expert in optical endomicroscopy, and I would say it's somewhere between 10 and 15 cases. So, I think that depending on your endoscopy skills, your ability to stabilize the scope and the image, those are probably the biggest things. So a very short amount of time. And they have a great video atlas that's in every unit that can really help you along. And then there's an active online community as well. So we'll go ahead and move on and let you take it away, Mike. Okay, great.
So, so let me share my screen here back again. And we're going to talk a little bit about volumetric laser endomicroscopy. And I will fully admit that when I give a talk by myself, I will show the CLE data, some of which Tripp showed, and one, the Don't Biopsy trial, which is perhaps one of the best named trials I've ever seen. I will show that data. And then I'll talk about the fact that, we get great resolution. You can see down to 1 micron of resolution right at the surface level, as Tripp showed you very nicely with the images that were displayed in his slides. The problem is that you're really able to look at a terrifically small area with terrific detail, but getting across the entire segment really can be a problem. And in the old days, what we used to say, well, let's see if we maybe could see something in endoscopic ultrasound. Many of you may remember that the guidelines, the suggestions were that maybe you should use endoscopic ultrasound in any patient with high-grade dysplasia to see if there was something that was potentially an early cancer invading into the wall. And we know from our data that, in fact, the ultrasound technique does not work particularly well to look for early disease, either certainly non-invasive or minimally invasive, into the proximal submucosa, for example. And so there's been a push to find something that's sort of in the middle ground there, and one that has come up has been what we call advanced OCT or VLE, volumetric laser endomicroscopy. This is VLE is a next generation version of OCT, optical coherence tomography, that provides resolution down to about 7 microns, so not as good as the 1 micron of the CLE, but you're able to see 3 millimeters, into the tissue, even into the adventitia, as I'll show you, of the esophagus. And so to look for disease that's not just right at the surface, where you may have dysplasia and neoplasia working its way up from the basement membrane area at the bottom of the lowest regions of the mucosal layer, that wouldn't be apparent yet at the surface, but may be indicative of something that needs to be resected or at least targeted for biopsy. Something that would be missed on CLE would be there. The other thing is that it uses a swept source laser. And so over the course of 90 seconds, about the same minute and a half that Tripp was mentioning before, you're able to see a 6 centimeter segment of esophagus, or any GI lumen that the probe is able to fit into, circumferentially. And so the ability to cover that amount of ground in that short a period of time and to a greater depth are things that CLE cannot provide. You do sacrifice the resolution at the, in terms of not being able to see at a cellular level, but you are able to see enough evidence of distortion of the normal architecture that it can key you into where you need to take your biopsy. And it's done using a console where the laser is in the bottom half of it. And that attaches to a balloon-based laser probe where a helical pullback occurs in order to pick up your images. There are 1,200 slices that are obtained, as you see on the right-hand side on the user interface, in that 90-second frame over the 6 centimeters. And there are vertical reconstructions as well. And once the images are generated, you're able to scroll along them, much like you would read a CT scan, to look for areas of concern and then go back and target those for sampling. In a normal squamous epithelium, you can see it looks a lot like the layer cake image we all saw in our histology textbook back in the first year of medical school, where you have the mucosal layer, the lamina propria muscularis, the submucosa muscularis propria, and then the adventitia all the way out. When you lose that normal layer cake appearance, you have to worry about metaplastic disease. And then when you see these bubbles, these areas where the architecture does not allow for tight packing of the tissue like a normal villus epithelium would, when you've got dysplasia present and the glands are overlapping and crowding each other and irregularly shaped, you get these potential spaces. And that's what you're seeing here on the VLE image, where what are called irregular glands and ducts, but they're probably to some degree potential spaces created by the distortion of the architecture at essentially a subcellular or a pericellular level. When you see these, you've got to be very worried about dysplastic disease, and you can target this area for tissue sampling. We did a 1,000-patient study at 18 sites across the United States when this device first came out. A very large number of those patients had either possible or definite Barrett's on their initial endoscopy. That group then had VLE imaging, and over half of them had at least one suspicious area that was not seen either on high definition white light exam or narrowband imaging or CLE or any other digital chromoendoscopy. And in fact, in that group, there were dysplasia detected in 52 of those cases. That was just over 1 out of 5, including 27 cases where only the dysplasia was only found on targeted biopsies. So your adjunctive yield there was 108%. And the number needed to test with the VLE to confirm an additional case of dysplasia on histology with a targeted biopsy was less than 9. So very good preliminary data showing, again, the ability of this device, which is able to scan the entire circumferential esophagus deeper than the surface layer in just 1.5 minutes, looking very good at the early stage. And it's important to note that the ability to target your biopsy initially was based on triangulation, based on a long, thin black line that was painted onto the balloon. Subsequently, after this study that I just showed you was finalized and completed, the ability to laser mark the area with 2 white dots, as you can see on the far right side, based on the abnormal findings on VLE has become available. And in fact, you can see in the third panel over a magnification of the area between the 2 red lines, which are the sight lines for the laser, where you can see this abnormal glandular material that's deeper than the surface, and you see that there's no normal wall layering pattern that you would see with squamous epithelium. This area was then laser marked, as you see on the far right, and an endoscopic resection was performed revealing deep adenocarcinoma. And so in fact, this device, because of its ability to see below the surface level, gives you something that CLE or NBI or any of the other digital chromoendoscopies don't have, which is the ability to look below the surface. And in fact, the addition of the laser marking is shown by Arvind Trindad and his group, showed that with looking at adding the laser marking to the Seattle protocol with looking at studies of 2 cohorts of consecutive patients, you can see that the yield of both dysplasia and neoplasia by adding in the real-time targeting, the other name for laser marking, was statistically significant in both of those groups for dysplasia and for neoplasia when you compared the laser marking group to the group that only had Seattle protocol biopsies. And so adding that in needs to be taken into account as you think about those initial results with that 1,000-patient study where the laser marking was not available. And in fact, I want to show you two cases where I used laser marking that sort of highlight this point for finding dysplasia. This is a gentleman, 64 years old, who came to me for recurrent low-grade dysplasia from his primary gastroenterologist. He had a very normal-looking C0M2 PROG classification Barrett segment with nothing on the high-definition white light or NBI exam. But when we did his VLE scan, you could see that some of these bubbles are starting to break through what looks like the lamina propria and down into the deeper layers. And in fact, we laser marked this area and resected it, and we found a very small focus of invasive adenocarcinoma that went through the lamina propria, but not the muscularis. And in fact, this patient had liquid nitrogen spray cryotherapy and has achieved complete remission of intestinal metaplasia on biopsies and post-ablation VLE scans as well. And here's a second case, very nice case with C0M3 Barrett's that was ablated very well with radiofrequency ablation. After 2 treatments, visually completely normal looking endoscopy, a mildly irregular Z-line if anything, but of course a Z-line is supposed to be irregular, that's why we call it a Z-line. No other focally suspicious areas on white light, on NBI. And the VLE showed this funky collection of glands with heterogeneity and foci of hyperintensity below the neosquamous epithelium. They were resected with an endoscopic resection, and in fact, there was high-grade dysplasia in this area, completely removed with an endoscopic resection, and an ability to move forward now with him being in a complete eradication of intestinal metaplasia and dysplasia as well. And there are multiple other cases like this in the published literature, but I wanted to show you two that examples very nicely of finding the dysplasia below the surface level that you can't see with any of the other technologies for imaging that we're talking about tonight. So I just want to end very quickly before I turn it back over to the rest of the group. The VLE, as you saw, was on a laser balloon. This is a small capsule on a string that's got the VLE laser inside of it. And this poor graduate student has electively chosen to swallow it and is getting a real-time VLE of their esophagus to look for Barrett's and, of course, dysplasia. And in fact, with the setting of artificial intelligence, which is now being added in as part of the processing to look at these images, the ability potentially of this kind of a device to be used in an outpatient setting to find the disease without even having to send the patient for endoscopy or tissue sampling may be something that'll be available in the future to all of us to screen our patients who have a higher risk of developing Barrett's as a result of their GERD history and some of the demographic factors that Tripp mentioned earlier in the talk. So with that, I will turn it back over to Tripp and to Dan and see if there's any questions that have come up, but I know we're getting close to the end of the hour, so maybe we should hold till the end.
All right, I think we should hold to the end. Dan, why don't you run in and talk to us about Watts?
Okay. So Watts, or wide area transepithelial sampling with computer-assisted analysis, known as Watts 3D, is a very great technology in my opinion. It uses an abrasive brush. It's a much stiffer brush than your regular cytology brush. And it's able to sample the entire thickness of the squamous and glandular epithelium. The specimens come off in tissue fragments. And then the slides are then, you basically get a clump of 150 micron thick tissue that the computer, using a technology called extended depth of field, can basically slice through this in 1 micron slices, and then the computer can recreate in 3 dimensions the glandular architecture. So it's almost like taking a CT scan and doing a reconstruction. And it allows then the computer, using artificial intelligence models, to pick out the most worrisome cells, which it then presents on the screen to the pathologist, and the pathologist can look at them with a variety of stains to give a diagnosis of Barrett's or dysplasia. And back to the slide that, you know, the infamous dartboard throwing of Seattle protocol, one of the biggest advantages of Watts is you're able to biopsy a significantly larger amount of the tissue in a very short amount of time. So rather than the 4 little biopsies, you're able to do a circumferential biopsy somewhere probably between 70 and 95% of the tissue, depending on how long the segment is and how aggressive you are with the brush. The other nice thing about Watts, and one of the poor things about forceps biopsy, is there is a very poor inter-observer agreement when they're looking for dysplasia in Barrett's esophagus with forceps biopsy, with a kappa value of around 0.3. In this study, they had various pathologists look at 149 Barrett slides from Watts, and the kappa values for agreeance for high-grade dysplasia in cancer was 0.95, 0.74 for low-grade or indefinite for dysplasia, and 0.88 for non-dysplastic Barrett's, which is far above what we can achieve with just forceps biopsies. So if you look at a kind of a summary of the different studies, some of these are, Mike Smith is has a huge patient population in this top study where they had almost 13,000 patients randomized prospectively. And the main findings were Barrett's had an increase in detection of 153% with Watts and a 242% increase in dysplasia. And other studies can show up to a 428% increase in high-grade dysplasia in patients using the Watts brush. One of the interesting things that have come out of this technology, using the 3D reconstruction and being able to see the glands in 3D, there has been a new subset of patients that have come out of this, and that is called crypt dysplasia. And crypt dysplasia is where there's dysplasia at the bottom of the crypt, but it doesn't make it all the way up to the top. And that's not able to be seen on standard biopsies. And originally, we didn't know what to make of that, but this study out of Nick Shaheen's group showed that it definitely has a different progression rate than non-dysplastic Barrett's. The non-dysplastic Barrett's to high-grade dysplasia or cancer progression rate was 0.33. The crypt dysplasia was 2.1%. And then the low-grade dysplasia to high-grade dysplasia or cancer was 7.71% in this study. So it definitely, when you get a crypt dysplasia diagnosis back, it is something that you need to pay attention to, and you need to survey those patients more aggressively or even ablate them to get rid of that risk of cancer. We have seen that Watts definitely can change patient management. In this study, we looked at whether patients had ablation, they had surveillance increased in surveillance, began on PPIs, increased their PPIs, and the total number of patients that were clinically impacted. And you can see in patients with Barrett's, low-grade dysplasia, high-grade dysplasia, in all groups, significant increase in a change in their patient management based on the Watts biopsy. So it really impacted these patients in a very important way to keep them from getting cancer, hopefully. One of the things that we've seen over the years is, as you can see in these different studies, as we've gone from 2011 to 2018, we've seen an increase in the yield. And part of that is because the company has been very proactive and has it not only increase the size of the brush and how aggressive the brush is, but also in tweaking the AI programs, it allows them to detect dysplasia and cancer more effectively. So it really increases the diagnostic yield of this technology. Just looking at my personal data, we looked at almost 3,900 EGDs over a 3-year period. 1,391 of those patients had Watts biopsies. And you can see here that the Watts increased my Barrett's detection rate by 52%. But what was much more striking is it increased my dysplasia detection rate by 825% in my subset of patients. Mike, I'm going to actually let you talk about this. Mike just got this published day before yesterday, or a few days ago. It came in my email talking about the cost effectiveness of Watts and how it is an incredibly cost effective method of screening and surveilling patients. Are you able to? Mike may be muted. Basically what they did is they looked at the different values of the cost of Barrett's detection with the brush, and using an ICER of less than $100,000 per quality adjusted life year gained, they were able to use different areas where using some really high false positive rates, which we really don't see, and the different increasing yield in Watts, you can see that all of these across the board had a much lower than $100,000 $100,000 per quality adjusted life year, which is the cutoff to be cost effective when it comes to insurance companies, which we all have to fight with. One of the questions I often get asked about is, how is this going to change time-wise for my endoscopy? And we looked at what the average time to do one 4-quadrant Seattle protocol biopsy. In our lab, it was 1 minute and 16 seconds. The average time to do a 5-centimeter segment with the Watts 3D brush, which is 2 brushes, was 1 minute and 15 seconds. So if you look at a 5-centimeter segment, random biopsy is going to take 6 minutes and 20 seconds, where you can do that whole 5-centimeter segment in 1 minute and 15 seconds. And you do use a different, the brush sets come in 2 brushes, and you use 2 brushes for every 5 centimeters segment of your Barrett's. In my patients showing the impact, I had a 57-year-old white male who had a C7 M11 segment of Barrett's. Pinch biopsies only showed indefinite for dysplasia, and he was sent to me for ablation. We did a Watts on him, which showed high-grade dysplasia, and he underwent RFA. Another 80-year-old gentleman with a C3 M6 segment, pinch biopsy showed non-dysplastic Barrett's. We did a Watts on him, and it showed high-grade dysplasia, and he is currently undergoing radiofrequency ablation. Various groups have looked at this. The ASGE came out with their guidelines first, stating that patients with known or suspected Barrett's should have Watts in addition to white light endoscopy with Seattle protocol. Our group, the American Foregut Society, looked at this, and the board concluded that there was sufficient evidence to support routine use of Watts 3D technology in the diagnosis and ongoing evaluation of Barrett's. And here just recently, SAGES, their Technology and Value Assessment Committee, Sean Suda, wrote that the Watts technology is safe and effective adjunct to biopsy forceps biopsy in the evaluation of Barrett's esophagus low-grade and high-grade dysplasia. So a lot of societal support for this technology. And with that, I'm going to stop sharing. And you know, the one nice thing about this technology, as opposed to everything else that we've talked about in the kind of advanced segment, is this technology is available with no capital outlay. So there is really no hurdle to getting this into your endoscopy suite. You're not having to spend $70,000 or $80,000 or $100,000 on a unit or on disposables. The company provides the brushes. They provide the boxes to send the specimens in to be evaluated. And it's a very cost-effective way of increasing your yield substantially.
So, one question from the chat, basically I'll summarize, is that, you know, are you concerned about brushing cardiac intestinal metaplasia? There's an anecdote of a physician who couldn't get life insurance because they suddenly had cardiac intestinal metaplasia based on a Watts. And I think you already answered the question about costs. It's effectively no cost to the hospital and or the patient, in that if they can't get reimbursed, the company eats it, at least for the time being. But do y'all have any comments on you know, diagnosing cardiac intestinal metaplasia, and is that important? Is it not? And then, you know, obviously what financial impact that might have on a patient.
So, you know, I would say this. I think it goes back to what are you sampling to begin with, right? And the ACG guidelines will tell you you shouldn't sample anything that's less than 1 centimeter in length. And I think it goes back to Dan's example of what do you do to do a really good Barrett's exam. Because if you've got a relatively regular Z-line or a mildly irregular Z-line that doesn't have a large tongue or a focal area that looks particularly concerning, it probably shouldn't be sampled for Barrett's. And if you're getting back something that says intestinal metaplasia, but you're really biopsying the gastric cardia, then you have to say that the test really only looks for, well, is there intestinal metaplasia? If there's intestinal metaplasia, then you need to put in the record, if you think it's IM of the cardia, that I believe based on where I biopsied, this is IM of the cardia. So in that particular case that was raised in the Q&A or in the chat, you know, in that particular case, the question is, what did you see when you biopsied? And if you saw a tongue that was 1 centimeter or greater, and you took a Watts of it and it shows intestinal metaplasia, I don't know how you could say it's IM of the cardia. But if you didn't see anything and you're just biopsying a regular Z-line, or even an irregular Z-line, I'm not sure that you should be doing that unless advanced imaging or high definition white light focuses you on a particular spot that you think may be an ultra short area that looks like it could have dysplasia. And in that particular case, you should be taking a targeted biopsy, not a field biopsy like Watts. Watts works better when you're biopsying the whole circumference or the whole area of Barrett's to see if there's any dysplasia present. It cannot localize the way that a targeted biopsy can. And so and that would be how I would answer that question. And you're absolutely correct. If the Watts is not covered by someone's insurance, the company actually hands out a pamphlet that you can give to the patient that says they won't be liable for the rest of the bill.
I think you left out the option of looking at that area with optical endomicroscopy.
I think that actually, I would agree that would be a very good potential use of that technology. The CLE for an ultra small area that's of high concern that you want to look to see how far does it extend and decide how much you may need to resect would be a terrific use of that. And there he goes.
There you go. All right. Well, we are way out of time, and I want to thank everybody who's still on. We have a few people starting to drop off, but the vast majority of people stuck it all the way out. So thank you very much. I thought this was a great discussion. I love the format personally of at least being able to chat between ourselves and then answer questions. We'll end there, and everybody have a great night and great 4th of July. And we're going to have continue these in the future. So thanks a bunch, and hopefully we can see everybody soon at the annual AFS meeting.
Thanks everybody for coming. Great to have you.
We had a